Hi, everybody, and I want to welcome you to today's webinar. My name is Steve Ambrose. I'm the host of the Innovation Accelerator podcast here at Innovacer, and I'll also be the moderator for today's engaging webinar on the digital transformation of health and human services. And Innovacer and AWS see a really bright future for our publicly funded health system, and that includes the stakeholders, the beneficiaries, everyone involved. And the leaders on this panel are going to discuss the evolving and the central role that data plays in helping to improve the way that the care is paid for, it's delivered, and also how it's measured. And during the webinar, we are going to invite all viewers to ask questions. We'd like all our attendees to just submit them through the Q&A button, and the chat is going to be disabled during this time. So again, hit the Q&A button, and please feel free to give us all your questions. And we're going to try to answer some of these if we can during the time the questions are being asked and answered. If the panelists don't get a chance to answer them live, we're going to make sure that the questions are answered through our team by responding back to you by email. And just to mention that you can learn more about Innovacer by visiting innovacer.com, and you can always contact us by emailing team@innovacer.com. And we also invite you to explore and learn more about the best-in-class Innovacer's FHIR-enabled data activation platform that's on AWS Marketplace. And these links are going to be shared in the show notes listed within this webinar. So without further delay, I'm pleased to introduce today's panel. And we are privileged and honored to have, first and foremost, Brandon Greify. Brandon is the Senior Director for the Government Segment here at Innovacer. He is also joined by Dr. Paul Grundy, Innovacer's Chief Transformation Officer. And I just want to welcome you both. I believe that Mary Sarah will be joining us shortly, but it's great to have you both on the panel today. And I'm going to go ahead and just open it on up here. There we go. Dr. Grundy, nice to see you.
It's a pleasure. Thank you.
And Brandon, great to have you aboard.
Yeah, and likewise. Pleasure to be here, Steve.
Okay. And do we have, let me just see. I think we'll just wait about a minute or so to see if that we'll be getting Mary Sarah to join us, and then we'll get started. And this is just a good opportunity, I think, also to just share a little bit, maybe, Brandon, if you could, about you've recently joined Innovacer, and it's great to have you on the team. And maybe what we could do is just start off and get a little background from you first, Brandon, about what brought you to this point right now in your journey in healthcare.
Sure, absolutely, and happy to. Yeah, I've been at Innovacer for about 7 weeks, and it's been an incredible journey already. I joined because I saw Innovacer was just making some tremendous progress in bringing innovation to the payer and provider markets that I thought was just so translatable and so frankly needed in the government market. And having worked in policy for a long, long time, including at the state of North Carolina, just saw, again, wonderful opportunities to, I think, move government healthcare, and in particular Medicaid, to where it needs to be, to move sort of the theoretical policy into the practical reality that I think our technology can offer. So excited to be here and ready for the conversation.
And Dr. Grundy, always great to have you aboard. We've known each other for years, and just share a little bit, if you could, with our audience as well. You've got a fascinating story. I'm sure they'd enjoy to hear.
Thank you for inviting me. Yes, I sort of started my career in government. I ended my career in government. I was the Minister Counselor for Scientific and Medical Affairs for the U.S. Department of State, the interface between health and foreign policy. I then moved over to be the medical director at IBM for a number of years. And while I was there, I formed a not-for-profit organization, the Primary Care Collaborative, which led the medical home movement. I've also been involved in government and health policy for outside the United States. I'm a healthcare ambassador for the nation of Denmark, where I worked for many years on the transformation in Denmark, the UK, Ireland. So, I left IBM about a few years ago, retired from IBM, and I ran into Innovacer, and they were doing all the things that I'd hoped we could have done at IBM and failed to do. So I became an advisor, and then I joined them full time a few years ago. But it's really exciting. I sort of see this journey through three legs of the stool. It's the cultural transformation that needs to take place. It's the payment change. There's only one way to hurt a cat, and that's to move the food. As long as you put the payment in the wrong place, you're going to get the wrong level of services. And lastly, and why I joined IBM and why I then joined Innovacer, is it really, you have to have the technology that allows you to understand what's happening across a very complex ecosystem of healthcare delivery. Everybody is part of a team of folks that care for them. And if they're not all singing from the same sheet of music and they don't have interaction with each other, things go wrong very quickly. And that's sort of what started my journey on the medical home movement. Was my former boss at IBM almost died of a drug-drug interaction, and we decided to change what we bought from the delivery of healthcare. So,
yeah. Well, thanks for that. And thanks for having you both on. I'm going to just jump right on in here. And let's start here. In commercial programs and ACOs in Medicare, there's been a bigger emphasis, as we know, placed on social determinants of health, as well as, whole person care and health equity. What's the current state of affairs, of Medicaid programs specific to these initiatives? And maybe what are some of the biggest gaps and needs around them? Brandon?
Sure. Like so many conversations, I think we'd be remiss if we didn't mention the impact of COVID-19 on Medicaid programs. It's shown just a really bright light on a range of opportunities to do things better. And one of those things is addressing the long-standing disparities that we've seen in health outcomes amongst marginalized or historically marginalized populations. And in doing so, I think it also gave us a tremendous push, not just to understand the importance of things like social determinants of health, but to actually go about doing something about it. I think SDOH has long been a buzzword that we've understood to be important. I think only now are we beginning to sort of wrap our hands around what do we do with that information? How do we deliver services differently? How do we incentivize outcomes differently? And so I think that's been one really powerful outgrowth. But in order to do that, I think we've had to first quantify the challenge. I think there's the old saying, you can't improve what you don't measure. And historically, we just haven't had the capacity to measure health holistically. And part of that is because we haven't had the right data. Social determinant of health data has historically not been a part of the Medicaid enterprise. But I think that's gradually improving. Things like standardizing social determinant of health assessments, incentivizing things like the collection of Z codes, investing in things like closed loop referral systems. I think all of these are working to help us sort of systematize data collection, allows us to measure, and then to then invest in sort of the right treatment capacities. I think the other issue that we've historically dealt with, and sorry, go ahead, Steve.
Oh, no, please go on.
Yeah, the other sort of key challenge there that I think we've dealt with, and I think that we're now beginning to overcome somewhat as we come out of the pandemic, is funding. Federal Medicaid rules just hasn't always allowed us to spend money on non-medical services. I think this administration has recognized some of the importance of creating some flexibilities and promoting opportunities to use things like social determinants of health and fund treatment for social determinants of health. And so things like waiver authorities allow us to begin investing in non-clinical services. So things like housing supports and employment supports, et cetera. All of the things that we have long known can contribute to health, but have struggled to find a way to fund. And so I think just recognizing it's important, measuring it, and then now finding ways to fund it and invest in it have all been really key, I think, recent trends I've seen.
Yeah, those trends are so important. And in particular, I think it's really been an eye-opener too, as you've mentioned, just how important the social determinants of health, not just are to outcomes, but to accessibility and to a lot of the areas that I think have been historically just, I wouldn't say avoided, I would just say, they just they just haven't been fully made aware to providers. And it's great that this is all starting to come together. And Dr. Grundy, please feel free to jump in anytime if
Yeah.
you have some thoughts on anything.
I
with
think,
this.
I think I'll illustrate this with just a story. I think that oftentimes helps. So we recently, working with one of our clients in Iowa, we recently began to get at the data around what was happening in the social determinants of health with the population. We began to see an uptick in hospitalization for our type 2 diabetics for hypoglycemic events. And when we began to really dive into the data around that particular group of people that were being hospitalized, what we found was a population in a few zip codes and a date time period that corresponded to the end of their pay period. We had identified a population that was running out of food. And if you run out of food, you're going to be hypoglycemic, right? And you're going to end up in the hospital, which is a very expensive way, to manage a population. Once we understood that, and we then managed to connect them through Aunt Bertha and other services to make sure that we could monitor that they were engaged with the food bank and they were getting food. We nipped that in the bud, and so it was just a delight. And I see that Mary's joined us, and welcome. And maybe you could comment a bit as well.
Yes.
Add a little color to the importance of the social determinants of health, and thank you, Mary, for joining.
Hey, Mary, nice to have you aboard.
Thank you. I apologize for my tardiness. Travels have been interesting today.
Well, it's great to have you, and thanks for making the time. And just as an introduction here, I do want to introduce you that Mary Sarah Jones is the Senior Business Development Executive for the Health and Human Services segment at Amazon Web Services, or AWS. So great to have you aboard, Mary Sarah.
Thank you. Thank you.
And we are just talking about right now the first question about the importance on social determinants of health and health equity and whole person care in ACOs and Medicaid as well. So maybe
Yes.
you'd like to chime in just a few thoughts on that.
Yes. We are seeing a lot of interest across Medicaid agencies in different service delivery models to focus on whole person care and more holistic service delivery models. There's a real emphasis in housing and behavioral health, for example, and also in substance use. We're also seeing some complexities, though, in terms of payments and relationships across organizations and the data sharing that's required to support those models. So right now, Medicaid agencies are working to get all the pieces in place. There's a lot of programs, whole person care programs, that have been supported through different waivers, which I know we're going to talk a little bit about later. But they're still in the early days. And the models are really growing as they bring in that data and the funding for the organizations delivering those services.
Brandon, I wanted to move in on this next question here. I thought I'd start off with you. What are some of the opportunities and common challenges, as you see it, requiring states to move into more of a cloud-based infrastructure compared to where they are now?
Yeah, sure. And I think once again, it starts with the pandemic, right? It shifted the ground underneath our feet. I think it highlighted the need to be able to meet urgent challenges. So things like demand for services became really unpredictable. Sudden shifts in remote work, particularly at government agencies. The need to get rapid answers to some challenging and ever-shifting questions. And so I think that's all things that sort of push towards the cloud. Because I think often when we think about investing in cloud, we think about techie answers, things like containing costs by sharing services and infrastructure, or improving security and data protection, or elasticity to scale up our compute resources. And I don't want to downplay all of those. They're very, very important. I'm just a policy guy, right? And So to me, moving to the cloud, allows Health and Human Services organization to focus less on having to maintain sort of the complex investments that they've made on technology environments, and just focus more on policy. So I think that frees us up to do things like sharing data inside and outside of Health and Human Services agencies. We talked about social determinants of health in our last question. So much social determinant of health data is already captured by other government entities. I think the cloud enables us to sort of streamline our ability to share. Second, and related to that one, the ability to develop these cloud native applications and use integrated data in a more seamless way for our citizens. Maryland's MD Think project is, I think, a great example of how to do this really well, right? The ability to not just lift and shift applications, but to use the movement towards the cloud as sort of an excuse is the wrong word, but empower us to re-architect applications to be more client-centric, allow us to share data to really get at some of the root use cases that we have and want to address in government.
So
Brandon,
the example that you just cited of the Maryland MD Sync program brings us to that second leg of the stool, and that is how payment occurs. What became important to the folks in Maryland was there was a cap on payment for hospitalization. All of a sudden, it was in their interest to keep a patient out of the hospital and not to have them in the hospital. That put a huge incentive on supporting social determinants of health and supporting these kinds of issues around that. And as we begin to see the shift towards value in payment, as we begin to see the country demanding that shift, and the federal government, with programs like REACH being developed, that payment change is going to be the most rapid we've seen in healthcare over a last number of years, in terms of, if you put the food in the right place, you're going to get the right level of services. And, so far the payment has been, pretty much in a place where a person who is hospitalized is a source of income versus a cost.
Yeah, and I want to just add to that and just move into this next question for you, Mary Sarah. This year, AWS released, as you know, AWS released a white paper on Medicaid modularity, and it addresses the changing needs from the states and moving from large scale, what we'd call maybe monolithic system implementations, into more streamlined Medicaid IT systems. And one of the recommendations in this shift is putting data at the center. And what I'd like you to do, if you could, is share some of AWS's key recommendations, if you could, please, with specific to putting data at the center in this transformation.
Sure. There's several points that I think really jump out as the key aspects or rules to follow. And the first one would be to make sure that you prioritize governance across the entire data lifecycle. So really starting with, what is the Medicaid organization, your organization, trying to achieve? And that should really be the starting point and the North Star, if you will, for managing that data and the governance across its life. The others is that we need to really showcase the importance of data in decision making. And modularity has raised this to a new level. So that data has to go across all of the models. And it's the piece that is the connective fluid, if you will, across the Medicaid system, which is no longer monolithic. However, it has still got to be cohesive and fluid. And so the data is the component that is really going to do that. To be able to utilize it for decision making, that data has to mean the same thing as it moves from one module to the next module. So that's going to be key. Throughout, we need to make sure that we keep both the patient and the provider at the center. So thinking about data is representation of constituents, the provider and the patient, right? That's how we understand how the providers are performing. That's how we understand how health is progressing with our patients. So we need to make sure that we keep that at the center and we understand that. Data ownership is another issue that I think is really important, and the cloud actually gives us some capability to work with that. So on-prem allowed us to keep the data in our ownership with data centers, but through a divided ownership, we do through the cloud allow the partners that we work with at AWS. They manage the data, AWS never touches it. So your business partners are working with that data and you maintain complete ownership of it, although it is no longer on-prem.
Gotcha. Brandon, I know you had a few thoughts on this as well. If you wouldn't mind sharing just some.
Yeah, I just wanted to lean in on one of the things Mary Sarah said, right, which is showcasing the importance of data and decision making. When she said that, it just reminded me of in baseball, we have something called the scouts versus scores debate, right? You've got old school scouts who just relied on their lived experience to kind of size up a player and whether or not they were made for the big leagues. You know, do they have the right frame? How's their throwing motion? How's their swing? Do they give me that right gut feel? Scores, on the other hand, they're data guys. They relied on statistics, analytics to determine potential value. They weren't looking at the players, they were looking at the numbers on a page. And Medicaid, you know, I think it's the same way. I think that there has been a shift from scouts to scores, but I also think now we're recognizing that there's not replacing historical knowledge. There's no replacing lived experience, but there's certainly a place for data to be able to inform decisions. And I think almost as importantly, to illuminate gaps in sort of our tribal knowledge, and just as important to push back on groupthink, which I think we're bad about in government, quite frankly. And so I think we've now arrived at this place where technology is no longer a blocker for us to be able to not just answer questions, but to rethink the questions that we're asking, right? We can now integrate systems and churn out just some incredible analytics. And so now the challenge is one of imagination. It's what questions do we want to answer? Are we asking the right questions? What new questions can we create if we're no longer bound by having to stay within the realm of what's collected on a claim or an encounter? And I think we can do that just by kind of, again, being really creative in how we think about data architectures. And that's, you know, allows us, you know, let's flow down from our new capabilities via this Medicaid modularity and our investments in cloud. I think it just opens up new realms of questions that we can ask.
Yeah. And you know, I wanted to ask Dr. Grundy, you know, with respect to public health programs, it's like Medicaid, how do you see data interoperability and also the unification of patient records playing a supporting role in both driving policy and administration?
I would say that, you know, I'm sort of known as the godfather of patient-centered medical home. And I would say the basic concept of medical home, which by the way, is a home for the data. It's not for the patient. It's not for the doctor. So Kal Shia, who articulated that concept, was dealing with children with special needs. Children with special needs have schools. They have clinical psychologists. They have social programs. And what Cal understood was, unless everybody has the same information working with that patient, the patient didn't do well. And I think that there have been really three breakthroughs in my lifetime in trying to drive the data that's going to do for the doctor's mind what X-ray and images has done for their vision, make it clear what they need to do for the patient, invisible. Those breakthroughs are really the cloud, AI, and blockchain. So without those breakthroughs, we really would never be able to get at, you know, the kind of data information we need to have to share across that spectrum of folks caring for patients with complex needs. And I think that increasingly, health policy and payment policy is beginning to drive that in a profoundly powerful way. And so I begin to see real changes in how we're going to be looking at a patient and how we're going to be looking at payment and all these other elements. And I think that's really policy driven.
Yeah. Mary Sarah or Brandon, anything to add?
Yeah, I couldn't agree more with Dr. Grundy, right? I think, it is so much about the data. And I think although Medicaid agencies have been traditionally data rich enterprises, it just hasn't always been the right data. I think claims and encounters can tell us a lot, but those types of data were fundamentally created to make sure a provider could be paid, not to improve population health or inform program design or drive policy change. And so I think, we're at a place now where Medicaid agencies can start thinking beyond claims and encounters. I think we already talked about beginning to collect information about a person's whole person needs. I think they're also now working towards incorporating clinical data into the enterprise. Because I think it's not a nice to have anymore. It's an inevitability, right? I think it's needed to be able to drive things like value-based care initiatives that Dr. Grundy has talked about. I think it's really critical to be able to have a closer to near real-time interaction with providers. Because I think we've been historically stuck in a rut of thinking about interventions based on retrospective analysis of already lagged claims data, right? We're dealing with what happened a year ago and hoping that can effectively influence policy that we want to implement in a year from now. And I think things like clinical data really allow us to move up those decision-making timeframes and also to put the outputs of those analyses back into provider and payer workflows so that we can see rapid results much more quickly.
Yeah. And if I could add, one of the things that I think is really exciting that speaks to that, Brandon, is the inclusion of the closed loop referrals. We're seeing a couple of states take that approach where at a state level, they're incorporating a closed loop referral, often connected to the health information exchange, but not always, as a mechanism to be able to capture a lot of the social determinant of health data and then be able to have that more holistic view of the individual. And we're seeing that in some cases be covered by some of the Medicaid funding.
And Mary Sarah, can you just for our audience, I'm sure they know, but just to bring it out there, closed loop referral, define that for us.
Sorry. A closed loop referral is a system that allows providers and sometimes the patients themselves to create a referral to different supportive services. So maybe to a food pantry, or maybe for housing supportive services if somebody is housing vulnerable. And when that referral is created, instead of it going into a black hole and the provider never knowing whether it's a healthcare provider or another community service provider, never knowing if the patient received those services, the provider is able to see from the beginning to the end. So they're able to make sure that their patient is receiving the care from other organizations that that patient needs in order to have the outcomes that they're driving toward.
Right. Now, I'm assuming.
And to animate that with a story, Governor Douglas in Vermont some years ago, IBM was the largest employer at the time, so I happened to be working closely with them, created what was called a blueprint for health, which was a closed loop for healthcare. And they took 2 cents out of every sick care dollar and created 11 agencies across the state that coordinated the entire support for the social determinants of health behind the doctor. So it was the community coordinator, not a clinical coordinator. So, if a newly diagnosed diabetic was seen, they could be referred to the grocery store, which did a walkthrough and teaching them how to eat, et cetera. So what we saw in that, I went and spent a week in St. Johnsbury and looked at this and studied it. What we saw in that was a 2/3 reduction in the complication of our diabetics. That's 2/3 less hospitalization. That's 2/3 less loss of eyesight and limbs, et cetera, because, all those social services were integrated, into that closed loop with the primary care provider, with their medical home. Profoundly powerful. And that's what we do in Denmark. That's what, they try to do in the UK and other economies. But that concept of the data being in a closed loop and integrated into support systems that Mary Sarah mentioned is just immensely important if we're really going to make a difference.
I want to jump in here with our first question from our attendees, and that is this: how can states intelligently do a modular procurement? Is it relying on system integrators becoming the future? And maybe Mary Sarah, I'll hand that one off to you if you're comfortable with that.
So states are taking different approaches. Modularity is a little ambiguous. And so some states are, most of them are utilizing, or many of them are utilizing system integrators, but I don't think they're entirely stuck with the system integrators. And it's really more about making sure that the systems themselves provide that data that they need. And again, it's back to the point of governance and really understanding what the Medicaid agency needs. We're seeing many states beginning with the system integrator as the original module or the first module to pursue. And I think that's because of that importance of the data, and this, having the system integrator at the beginning allows them to set up that framework that all the other modules can then snap into. And so I think that's a learning. Now, we have to take into account, though, that modularity is new for Medicaid, and there's still a lot of states that are not very far in down this road yet.
If I could add to that, the whole concept of the patient-centered medical home is that system integration occurring in a trusting relationship between a patient and their healer. And what we discovered in many parts of the world where the systems work is that is the most powerful tool you could have, is relationship of trust between the provider, between the healer, in the case of the patient and the patient, with the data available to effectively communicate from that system integrator at the primary care level.
Yeah, that's interesting. And Brandon, I know that right now that enterprise data warehouses, they certainly play a role in state Medicaid agencies, but now more than ever, we're looking at new ways to complement them, to get better data-driven insights, better analytics from them. And maybe I'd like you to share a little bit more on how some of that is possible and what's going on along improvement with EDWs.
Yeah, absolutely. And I think some of this flows from what Mary Sarah was just describing, right? Of this concept of modularity is still new. We have seen some trends, sort of early procurement of a system integrator being one of those. But I think that there's some innovation that we're already seeing in things like a data warehouse module. Some of this may be semantics, but I think in general, we need to move beyond the concept of a traditional data warehouse. And to do that, just to back up a step to some of the themes that we've already talked about, right? Breaking up these monolithic MMIS systems because they were inflexible, they were difficult to configure, they're expensive to maintain, and we've moved towards more nimble structures. I think when it comes to data warehousing, we ask the same questions, right? Data warehouse can be, if we architect them this way, another monolith, just a smaller one. A small monolith, if that's a word, it's an oxymoron in terms. It's like jumbo shrimp, small monolith. But just to get nerdy for just a little bit, when thinking about data warehouses, I think some of the challenge that we've had is that they do what we call application specific binding. So we're creating ETL and data ingestion processes that ultimately are designed to feed data marts, and those data marts are designed to help out particular divisions or respond to certain functions that an agency has. I think that creates some inflexibilities, and I think it adds time intensivity if we want to change them. So we've started to invest in things like data lakes, right? Don't suffer from that same problem, but have some of their own challenges as well, in the sense that they take a lot of meaningless data and put it all in a place where we can begin to extract some value out of it. But without sort of careful tending, it can also just become a disorganized mess. And so I think that's where the concept of a data lakehouse as a complement to a data warehouse can be really important. I think that provides some context around things like vocabulary, so that we know we're going to be dealing with ICD codes, as an example. I think it allows us to give certain rules like length of stay, some things that we know we want to be able to measure. It allows us to do that early on in the process. So we provide some structure, we gain the benefits of structure and management that we would traditionally associate with a data warehouse, along with some of the benefits of a data lake, like low cost storage and flexibility. And so I think that's where we want to see sort of the innovation begin to spur, is thinking differently about data lakes, data warehouses, towards these newer models that I think allow Medicaid agencies to dream up awesome use cases and execute on them.
Yeah. And if I can build on that, I think that's exactly right, Brendan. And people are starting with the data warehouse as the solution, and thinking, what questions do I want my data warehouse to answer? And they're building their data warehouse to answer those questions. And then that becomes a point in time solution. So that is going to be accurate now. And that works for those questions that are going to be consistent from one day to the next. And there's a lot of those. So it's not, I think we're going to continue to see data warehouses, but there's a lot of questions that come up that you didn't know yesterday you were going to need to ask. And those need to be answered quickly. And we're seeing that agencies don't have the nimbleness to be able to answer those as quickly as they would like to. And so there we start seeing data lakes. And one of the really nice things about a data lake is you don't have to know the questions in advance. You can just bring in the data. So instead of starting with a strategy for data warehouses or data lakes, it's helpful to think of a data strategy more broadly. And what is your data strategy going to do? And that could include multiple data lakes over time as needed, your data storage needs, as well as a data warehouse. And then you've got a more complete picture that allows you the robust nature of that data warehouse and the nimbleness of that data lake.
This makes so much sense, obviously, to all of us, and I'm sure to much in the public health segment. Why have the solutions been slower to adopt with state agencies? I mean, they should all be lining up, conceivably for this. If there was ever a better case and a better time. But why has that been? Why has the case been one of slower adoption up to this point?
If I could answer that, this is not rocket science. This is a whole lot more complicated than that. To deal with 100 diabetics, each with their own personality, each with their own issues, is just a gazillion times more difficult than understanding the physics of our atmosphere to launch a rocket to the moon. And so, I think that's part of the reason why it's really taken some of the breakthroughs that we've now seen with AI and with blockchain and with cloud, to get us to a point where we can really begin to get at, the complexity of the data. But to put all this into sort of the simplest terms for the audience, it's the way Amazon shops you. It's the way Google Map drives you. It's the ability to get at the information that you need to activate a patient to do the right thing. we deal with these data lakes every day, you know, in our world that we live in by driving and Googling and all these other things. And it's taking some of those concepts and with the technology that allows that to happen and applying it to healthcare. If that's a simplistic answer and too simple, then Brandon and Mary Sarah can correct me on it. But that's the kind of the way I think about it.
Yeah, and I think what you're speaking to there is it's about people, process, and technology. And the people aspect of it is often the most complicated and takes the longest time to change. And we're creatures of habit. And so I think that's part of it. The other piece is that the procurement process is really quite cumbersome, and part of modularity is trying to reduce the lift of those procurement processes, but it has a long life cycle in itself.
The only thing I'll add,
yeah, please go ahead,
you
Brendan.
know, just recognizing the difficult jobs that so many in government face, right? It is a full day's work to keep the lights on, to keep operational processes moving. They don't always have time, bandwidth, energy, or money to begin thinking about what comes next. What is the innovation that I need to be thinking about, focusing on, and investing in? And so I think, you know, some of it is just time, demonstrating success, and then just kind of helping states from a consultative capacity, just think about the art of the possible and what that means for all the stakeholders in Medicaid, the patients and the beneficiaries, the providers and the payers. So
yeah, if just one more point, that's a really, really important, there's a lot of really wonderful solutions out there that agencies could adopt, but the question is, what do they have the resources and what is the burning platform? And so good ideas in themselves are not enough. They need to be solving the problem that it's worth putting those limited resources toward.
Yeah, let's talk about some examples here. Now, Innovacer is working with one of the largest public county health departments in the US, has about 1.6 million residents. And I know that AWS has had success, particularly in working with the Kansas Department of Health and Environment. And so both of these programs are really helping residents to connect into specific services and get access and a lot of other benefits where data plays a key role. So I wanted to ask, specific to health equity, what are some of the limitations around data and insights today? And how do cloud-based, or what we'd call data activation platforms, make a difference with that? And Dr. Grundy?
Yeah, so, you know, again, I would like to tell a story, and this is a story of a working single mom, children of 3, full-time employee, and I had the privilege of actually being in a practice that was caring for this woman, and you know, what I discovered was that with that active data activation platform, the doc had all the information they needed from disparate sources, from claims data, from clinical data, from the state exchange, that came in as a virtual huddle. It came into the person calling to confirm the appointment the next day, and they could begin to act on that. That information saved the doc about 3 minutes of time to actually spend in that relationship with the patient, which made a huge difference. And what really impressed me was that when I walked out with her and was visiting with her as we walked out to the parking lot together, the basic information that she needed to follow up with was already texted to her cell phone, right? And you know, and we now know in the way that Amazon shops you, that a woman with 3 kids who works full time, the best time to reach her is after 8 on Tuesday, right? That's AI. And the best time to follow up with her with what you need to tell her is 2 days later after 8. But that's the way Amazon shops you, right? That's the messages you get. It's doing that sort of thing with an activation data platform that can really sort out the information and save the folks in the clinic a huge amount of time and effort, but yet be smart in the way that, in the way that Amazon shops you, right? In the way that Uber drives you. Yep.
I just want to move forward here. Just in the interest of time, I want to make sure we get all these points in here. Brandon, a number of states, including California, are taking steps to transform Medicaid programs through what's called CMS's 1115 and 1915B waivers. And I'd like you to share a little bit more about what these programs are, how are they playing a really crucial role in population health and also in whole person care with beneficiaries.
Yeah, absolutely. I think the promise of 1115 waivers is immense. And so, we've often said that states are laboratories of democracy, and I think 1115 waivers allow us to turn health and human service agencies into workshops of Medicaid policy. It's about testing a hypothesis. The rules and regulations associated with delivering care in Medicaid, very well intentioned, but can also be in some cases very restrictive. And so 1115s enable some exceptions to those stringent rules so that states can test opportunities for improvement. How can we increase access to care? Is there some delivery systems reforms that we can improve health outcomes? Can we implement some incentives to address social determinants of health and work towards more holistic outcomes? But key to all of this and key to 1115 waivers getting passed or accepted by CMS is being able to measure what's working. And historically, we've done not the greatest job at that. The GAO actually came out with a report not too long ago that said 1115s don't provide enough information for policymakers to actually understand the waiver's impact. And CMS has been taking some really good steps recently to implement monitoring and evaluation resources to help with things like designing these waivers, identifying the data that's needed to monitor outcomes, and then preparing reports. But some of that is really technical, right? Like it's helping states to put best practices for causal interference in place, or how to design synthetic control methodologies. And I think leaders understand that that's important, but they, at the end of the day, just need to know what worked and what didn't. And I think, that's not just past tense, understanding, again, what worked and what didn't, but what's working and what's not working. And I think that's where there's just a tremendous opportunity to, again, move from retrospective views to more prospective and predictive views. And that takes more than just evaluation. It takes some of the things that we've talked about, being able to invest in these robust data infrastructures to do the ongoing and constant analysis of health utilization and outcome, so that we can see and more rapidly pivot towards new innovations that we think can achieve the outcomes that we want in our programs.
Yeah.
One thing that's exciting about the 1115 waiver is that, in a state applying for that to the federal government, they look very, very favorably at when you do that. You're integrating the CHIP program, you're integrating housing program, you're integrating those other social determinants of health need program right into that Medicare responder, or into that waiver, in terms of how the federal government will support a state with Medicaid, if that makes sense. But at the very core of what that program is about is integrating some of the social determinants of health issues right into the program.
Mm-hmm.
Yeah.
The flexibility that 1115 and 1915B waivers provide really allow the state to meet the needs of their constituents, because states are different and they come from a different perspective on exactly what Medicaid is going to look like in that state, which is still within the federal guidelines. And the needs of their populations vary from state to state slightly. And so this really allows them to lean in on that. However, they do require that the states are cost neutral and have healthy benefits from those programs. And in order to be able to document that that is the case for the waivers, there needs to be a lot of data collected. not just a lot of data, but a lot of data that can then be turned into good analytics and insights. And that's what's really important, and where cloud can come in, and Innovacer, and really help them be able to provide that information.
Yeah, let's shift our topic for just a sec here to alternative payment models, APMs. One thing I want to ask is, and I had read that according to the American Journal of Managed Care, currently 26 states mandate some type of APM into their contracts, and 18 states in particular have established specific spending targets on APMs for their Medicaid MCOs. And so as states move into greater levels of value-based care, what are some of the gaps that you all see, and some of the needs that really need to be addressed? And how is data activation going to play a big part in that?
So if I could start by just telling another story. I was looking recently at a paper of a town in Texas where there were 15 people who ran up a cost of over $2 million in emergency room visits and hospitalizations. And none of them, you know, I mean, none of them had private insurance, right? And I mean, by more effectively managing that population, for example, as I described in what was happening in the state of Vermont, I mean, the savings is just phenomenal. So it's not very difficult to demonstrate no change in cost with the 1115 waiver. You know, if you can keep people out of the hospital by proactively managing them, getting them the food they need, getting them in CHIP programs, getting them in, you know, in support programs, getting them in housing, et cetera. And yeah, I mean, it's just phenomenal, the waste that we have with this in and out of the emergency room, in and out of the hospital for a simple chronic disease that can be managed remotely, can be managed, you know, out in an ambulatory way.
Brandon?
Yeah, I think it's one of those things that we're beginning to see a dramatic shift in how states think about implementing APMs and move towards value-based payment. I think, you know, previously there was this bent towards just including some requirements in managed care contracts that the MCOs then set up value-based payment with their providers. And I think states are now wanting to take more direct ownership in the design of those value-based payment approaches to be able to address some of the key policy priorities that they have and want to implement. But in doing that, I don't think that we can, we don't want to move a step away from the providers. And so, you know, one of the things I hope states begin to think about is how can we make sure that as states are working to design, develop, implement, and measure value-based payment approaches, that we're putting some of that information back into providers' workflows so that they know where they stand, so that there can be some interaction between states and other stakeholders in value-based payment, because everyone wants to move the needle on health. Everyone wants to help get patients get better. Let's begin to think of this as a team and let states be part of that care team.
Yeah, we're running a little short on time, and I want to save time for questions from our attendees, but a very quick question where I need maybe some quick answers, if okay. What type of consumer data or third-party data, you know, would you all feel is essential but not yet included when we talk about, you know, data that needs to come together in terms of, you know, whole patient care and helping SDOH and you know, managing better outcomes? So I'll just throw that out for quick answers.
You know, I mean, I think understanding the financial risk that a population have is really important. I mean, I think there was some data that something like 40% of our population couldn't come up with $400 in the case of emergency. I mean, knowing that information really helps understand what you need to do for that patient.
Affordability, that's yes.
In San Diego County did an analysis, a report years ago, and they identified that there were 3 behaviors that drove 4 chronic illnesses that were responsible for 50% of the preventable deaths. And those 3 behaviors were smoking, exercise, and diet. And I think those are the 3 areas that if we could have more information on those areas so that we understood if patients and individuals were eating and had access to healthy foods, for example, if they had access to safe parks and could take a walk, things like that would be really helpful for addressing those chronic illnesses and the preventable deaths.
Yeah.
Okay, got to
And-
move to the lightning round here. We got questions coming in from attendees. A question that's coming in: how can we rely on the data quality with these large data lakes and warehouses? Brandon?
I mean, I don't think we can rely on data quality coming in, right? I think it is making sure that the platform investment and just technology investments generally have the capability to promote semantic interoperability, right? Make sure that everyone is agreed on the language of data, and then be able to create a feedback loop of quality to the data provider of, this, are we missing fields? Are there fields that, we're seeing not aligned with what we would expect to see? And so it's just making sure that, the data lake house technology provider offers that platform that has data quality processes sort of built in.
Mm-hmm. Yeah.
I think one of the big breakthroughs is the ability, and one of the founders of Innovacer was actually one of the guys who helped develop this, was the ability for AI to check on itself.
Mm-hmm.
So we got to the point of like 88.7% accuracy when I was at IBM, and we worked a lot on that, right? But the ability for machine learning, for AI to actually examine itself effectively has now taken it up into that 99.97 range, and I think that is a huge breakthrough. I think securing the data is another thing that has been a huge breakthrough, and then being able to put this all in the cloud is the other breakthrough. So I think that we're finally reaching the point where we can process this data, handle this data in a much more effective way than we did even a few years ago. And I think that's going to make a huge difference in our ability to get that data to the right place. And that's the system integrator, right? That's the point that allows that to transpire.
Well, we're coming up to the top of the hour, so there are many more questions that have been asked here. Please, for all attendees, just know that all your questions will be addressed. You'll be receiving answers back from by email through the Innovacer team, so please watch for that. And I want to thank Mary Sarah, Dr. Grundy, Brandon. Great to have you with us today. Certainly a privilege and a pleasure, and your insights and your time are greatly appreciated. Again, thank you for being on the panel today.
Only a pleasure.
Thank you.
Thanks, Steve.
Terrific.
Really appreciate the conversation.
Me as well. And just for our audience, if you want to know more about Innovacer and AWS, please check our show notes, and feel free to visit respective websites. And I'm Steve Ambrose, wishing you a great rest of your day. Thanks for being with us today.